I'd like to deeply thank Professor Gianesini and all the SIDV group for the invitation to present together the concept of never treating a stranger, never killing a friend that was taught to us by Professor Caprini. Never treat a stranger means that we should never treat a patient as a stranger of whom we don't know the risk factors. We should indeed treat the patient as a friend of whom we know all the potential risk factors for venous thromboembolism, so that we don't get the risk of killing our friend by thromboembolic events. Reason why, together with Professor Caprini, we developed an app that is available to put in contact the patient and the health professionals for proper risk assessment. No conflicts of interest related to this topic. That is indeed interesting, because coming from the vein world, we understand that in reality lungs are a pathway to the heart, meaning the cardiovascular diseases, as per this interesting editorial that is pointing out the shared risk factors between venous and arterial cardiovascular diseases. This is quite impressive. If you dive into the literature, you see the percentage of patients that might be affected by heart failures, acute coronary syndrome, ischemic stroke, venous thromboembolism in the varicose veins population. So we understand it's clearly not just an aesthetic concern. This is clearly evident also in this kind of publication, where you can indeed see that higher CF clinical classes had a higher predicted 10 years risk for cardiovascular diseases in individuals that were free of cardiovascular disease. At the same time, it is important to remember that the CF clinical class is not a severity score. If you look at this interesting publication, you will see that the variations in the pathology scale of the histologic findings of the varicose veins are not correlating with the CF clinical class. And this is evident when we see that there is potential sign of disease when there is not even the disease. For example, in subjects in prolonged sitting or standing for occupational reasons, that indeed demonstrated to have also a significantly higher risk of PE and potentially also an increased risk of DVT. So it's very important to address this issue to all the population, particularly if we consider one of the cardiovascular factors, considering that there has been indeed quite a literature along the year on this topic. And we have data that we should always remember, like these ones that are showcasing how varicose veins patients that have an odds ratio up to 5 and more for DVT, PE 1.73, but also interestingly in the peripheral arterial disease, showcasing that indeed the venous inflammation goes also with the arterial inflammation, and the two things might be connected. This is evident when we looked also at conditions like unprovoked venous thromboembolism on the impact on mortality and major cardiovascular events that are actually higher for prolonged years after the first event. This is evident when we look at papers also like these ones that are showcasing the overlapping between peripheral arterial disease and venous disease, in particular PAD and chronic venous disease, with arterial disease predisposing potentially to varicose veins as per this publication. Even more, the underdiagnosed part of patients that are presenting peripheral arterial disease that are actually having also a concomitant chronic venous disease, according to this publication, in 21% of cases, but recognized that just in 18% of cases. So we have 4 patients out of 5 that are actually not treated for the concomitant chronic venous disease in peripheral arterial disease conditions. Interestingly, also the fact that if we have a failure of the calf pump, we have also a predictor of all-cause mortality. So really giving a sense of the peripheral heart, literally, in comparison with the central heart. Last but not least, it's also affecting gynecological patients. We have interesting data coming out from the gynecological world showcasing that 3% of all the women going to the gynecologist for whatever reason are actually presenting an incidental uterine venous plexus thrombosis. That is suggesting that the venous inflammation of the pelvic site might be indeed associated with an increased thrombotic risk, for which the score of risk assessment in general, and also the one of Caprini, might be of extreme importance, considering that indeed the endothelium is an organ that is affecting then all the organs in terms of potential pathology and in terms also of potential thromboembolic events. This is particularly important also in a COVID time in which we understood that a significant part of the population will remain in lockdown, meaning that rurality is an issue for health management, meaning that the vast majority of the population is living in rurality away from the health centers, for which it is important we have a proper management of the patients also by self-management, for which devices like apps can help in managing an endothelial inflammation that in terms of chronic venous disease is continuously increasing, considering also that the patient is continually becoming older, more obese, and more sedentary. That's why we invite you to download for free the app that is allowing, as I was saying, patient and doctor direct interaction, with also possibility of collecting valuable data for research, of course, in a protected way. Everybody can report eventually encountered mismanagement of the patients in terms of venous thromboembolic events, and not only. And also patients can be informed properly. So I invite you to visit the VWIN Foundation website dedicated to that, and I invite you to join us for the next VWIN activities in Albarella Island in North and East Italy. Very nice place. So we're gathering together with nice colleagues and friends to understand together what is vital we know in terms of the state of the art, and what is vital we keep on investigating because it's still an unmet need. Like to take the chance also to invite you to submit for the engagement working group at the International Union of Phlebology. The deadline is October 31st, if you want to be part of this global organization in an active way.
Hello, everyone. It's indeed a great pleasure to be able to come to you on the occasion of the 9th International Congress of the Egyptian Venous Forum. I'm honored to be in the presence of so many of my esteemed colleagues from around the world. I'm talking about thrombosis risk assessment before laser ablation surgery. Here are my disclosures. Thrombosis risk assessment is a very important and individual project. Treating everyone with the same anticoagulant strategy just doesn't make any sense. The risk of thrombosis varies widely among individuals. We use the 40-element Caprini score because it's a comprehensive instrument, and so many people around the world have worked on this and refined it. We know that as the number of risk factors goes up, the incidence of venous thromboembolism goes up. We know as the power of each risk factor is different. And when you combine the power of the risk factors with the risk factors, then that combination produces a score which goes up in a nonlinear increase according to the incidence of venous thromboembolism. Here are the results in general surgery. And right now the score has been validated in about 5 million patients, including more than 275 publications worldwide. And I would just like to acknowledge, since this is a worldwide audience, how grateful I am to all of you around the world who have helped show the good, the bad, and the ugly with regard to this risk assessment, and how we could make it better and what the pitfalls are. Just to highlight one of the reasons why I think that this is a really popular risk assessment. First of all, it's 40 elements. But also, let's take a look at this. Let us say you have a 42-year-old patient with a BMI of 29 on birth control pills. That's a total of 3 risk factors, and each of those risk factors in the Caprini score is worth 1 point. So the patient's score is 3. Now let's talk about a 76-year-old person who has a history of pulmonary embolism and a past cancer. That's 8 points, although it's still only 3 risk factors. So although each of these patients has 3 risk factors, the combination, the number of risk factors and their power result in a more accurate estimate of the VTE risk compared to a simple list of risk factors alone. And it also helps to dictate and refine giving anticoagulants to the people that most need it and sparing those so that you can spare any bleeding complications. Now, in 2012, the CHEST consensus guidelines decided that risk assessment using this score was something that should be considered. and they have made an evaluation based on their review of the documents at the time, which were very few, that if you had a Caprini score of 5 or more, that your incidence of VTE was 6%. Now in 2022, let's look back. We know that actually, if you had a score of 5 to 6 in general surgery, it was a little over 1%. It was less than 1% in head and neck surgery, and it was a little over 1% in plastic surgery. And in the almost 3 million patients studied in Vietnam, it was less than 2%. But look what happens when the score goes above 8 to 9 and above. General surgery, 6.5. Head and neck, 18%. Plastic surgery, 11%. And the big Vietnamese series, 4.5%. So the set point is different for different populations. Unfortunately, the set point for highest risk for patients having venous ablation procedures needs to be determined, and we're counting on all of you brilliant people from around the world to help us in this regard. We know it's a valuable tool, but we have to find out where it fits into the ablation picture. We do know that patients who do not receive prophylaxis and have a score of over 8 have a 10% incidence of venous thromboembolism, and this includes outpatients. Failure to provide prophylaxis for these patients may be a fatal error. Death from anticoagulant prophylaxis is rare when the score is low. Death from anticoagulant prophylaxis, sorry, it's a medical curiosity. People usually don't bleed to death from one dose of a prophylactic medication, but death from a PE is a very real event that can occur. What about venous ablation? Where is that set point without prophylaxis? Again, we don't know. And we're going to rely on studies going forward to evaluate that. Although the good news is the Caprini score is 40 factors, the bad news is it's hard to collect all that data. So again, look at all the brilliant people around the world that have created patient-friendly documents in their language in order that the patient can participate in this process. And here is a relatively simple but validated instrument that's been validated throughout the world for the patient to fill out. And notice here, obstetrical complications are calculated and tracked. Notice also here that family history of blood clots are tracked, not just thrombophilia. Thrombophilia is the wrong target because thrombophilia is a very minor part of the situation. If you have 100 patients that have a DVT, most of them you can't measure, you can't find a marker that's positive. And in those, the other thing about thrombophilia markers is that they're expensive, they're hard to do, and in some countries, the incidence of thrombophilia is markedly different than others. So it's really not a good target. You need family history. We know things run in families: hypertension, obesity, cancer, even heart disease, and also blood clots. Now, there is one other risk assessment that does feature the family history, and that's the Department of Health VTE risk assessment tool from the National Health Service in the United Kingdom. And they have a tool. It's a different score than the tool than the Caprini score, but it's a very good score. And it also counts family history of thrombosis. And they've done something even more important with that. They have enacted a law so that when you have to do the score in your patient and follow the recommendations, or you don't get paid. And doing that over a 2-year period, they saved 940 lives from fatal pulmonary emboli. So this really does work. And after a while, everybody brought into it. You know, it's like in the beginning, people were skeptical. They're saying, well, you're trying to tell us what to do. Well, it's just like with immunization for COVID. We know that saves lives and hospitalization. So the same thing here, implementing a protocol which is established based on enough literature, which is plenty of literature to show the value of the protocol, you can actually save lives. Pitfalls using the patient-completed form. Patients often fail to answer the family history question correctly. They often do not understand BMI. They often overlook pitting edema. without finger pressure. And they don't evaluate varicose veins, the difference between spider veins, telangiectasia, corona phlebitica, easy for me to say, and pitting edema. They don't really. This has to be done by the examiner, and the history of obstetrical complications is not fully understood. And to further amplify on this, if a patient has a history of a recurrent unplanned abortion, stillbirths, premature birth with toxemia, a growth-restricted infant, any of these difficulties may signal that that patient is carrying the antiphospholipid antibody, one of three different defects: lupus anticoagulant, anticardiolipin antibody, or beta-2 glycoprotein. And if they have all three of these, they're very serious risk factor for thrombosis. And sometimes females will carry this syndrome of antiphospholipid antibody through life. And so they're no longer having babies, they're no longer having any symptoms or anything like that. But this is an occult type of a thrombophilia. So you need to take this history to know who you need to do the test in order to calculate their real score if they're sick in the hospital or they're going to have surgery. Now, here's a study. We talk again about family history of thromboembolism, and this is the proper target. And this is a study that has not received very much publicity, but it's 183,000 people that were studied over a 25-year period. And the study shows that there's an increased risk in a person who doesn't have a personal history of thrombosis, but has a family history in a first, second, third-degree relative, or even in a spouse, slightly increased. That person is at increased risk to have a blood clot. The genetic component of the familial clustering of VTE is strong, even though we can't measure it. And family history is potentially useful for clinical VTE risk assessment, especially not only in these second and third degree relatives, but if you have a spouse that's had a clot, sometimes people that live together have similar lifestyles. So that may bear into it. But it's important to talk about this family history. Now let's talk about these minimally invasive surgical procedures. Here's an assessment of thrombotic adverse events and treatment patterns associated with varicose vein treatment. And this was 985,000 patients with varicose veins in a total of 131,000 patients meeting all the study criteria. 63,000 had multiple therapies, 17% laser ablation, 16% radio frequency, and 9.6 sclerotherapy, and 8.7 surgery. And what we see is that the incidence of DVT in radio frequency ablation was 4.86%, only 3.4% in surgery, very interesting, and 3.3% after laser ablation. On the other hand, pulmonary emboli, only 0.5% in either ablation with a laser or with a radio frequency, whereas double that for surgery. Very interesting statistics. They're a little old now. I'm sure they need to be updated currently, but it gives you a relative idea of what's going on. Now, this is a survey that is in a sense highly informative. One dose of low molecular weight heparin was used by 71% of the respondents for prophylaxis after ablation procedures. And there's no evidence that a single low molecular weight heparin dose in any way affects the VTE incidence. It's fine if you started ahead of time, and oftentimes in Europe for surgery, they start ahead of time, but then they continue it afterwards. It's especially useless in low-risk patients. And the patients at risk deserve a full course of therapy shown in clinical trials to be effective, not one dose. And very high-risk patients may even need extended prophylaxis. Now, here's some evidence going back to 2012. At the time, there was a Surgical Care Improvement Project VTE mandate that everybody had to have a dose of anticoagulation within 24 hours of surgery unless they were high risk. And in this VA study, there were 30,000 patients, and 89.9% of them adhered and had their dose. And the incidence of VTE post-op was 1.4%. 11% ignored the initiative, didn't have a dose. Incidence was 1.3%. The authors concluded in 2012 that there was no association between the VTE adherence mandate, giving one dose prior to surgery, and the incidence of postoperative VTE. Here is a study from Poland that's rather interesting. It's 141 patients undergoing saphenous vein stripping and mini phlebectomy with spinal anesthesia. Thromboprophylaxis with low molecular weight heparin was given for 10 days in all of these patients, and duplex scans done at 10 and 30 days. There were 5 CAF DVTs for an incidence of 3.5%. That's despite low molecular weight heparin prophylaxis, by the way. The Caprini score and the VCSS score were statistically significant predictors for postoperative DVT. The authors conclude that risk assessment should be done in all varicose vein patients, and future studies are necessary to confirm these results. An interesting bit of information to help us in this search for the assess points and what to really do. What do we really do for venous ablation procedures, especially too now with glue sclerotherapy and so forth? I'd just like to point out this slide. This comes from the Polish study. And recently there was a study that I participated in stating that perhaps we can have a shorter Caprini risk score for varicose vein evaluation, because I've been told that a lot of people get confused with all the risk factors. And of course, if you have a simpler score, it's going to make it much easier to get good data in everybody. One of the pitfalls of the negative articles in the Caprini score to date are people not asking all the questions. But I just like to point out here that sometimes there are patients with serious medical conditions that are undergoing venous ablation procedures, including heart failure, cancer, ischemic heart disease, morbid obesity, oral contraceptives, and so forth, and people over the age of 75. So it's something to keep in mind, and that's why I still advise doing a complete Caprini risk score aided by the patient in order to pick up these high-risk conditions. There is a series of studies from the University of Michigan. University of Michigan has done a wonderful job and has a beautiful record in this regard. This is the original study in 1,056 patients, and they were all given preoperative heparin, which was then continued for 1 week in those with a score of over 8, immediate ambulation and compression for 2 weeks, imaging at 7 days, 3 and 12 months, then yearly. And you can see the results here. Radiofrequency ablation, 1.5%, adding to the TIPS procedure, doubled that. E hit 2%, adding the TIPS procedure, increased that by 1/3. And superficial venous thrombosis, interestingly enough, with the TIPS procedure, actually it's not too surprising because of the nature of that, is all the way up to 6.4%. The authors concluded that ablation of axial reflux with the TIPS was improved outcomes and should be the first-line therapy for varicose veins of venous insufficiency. The standardized protocol led to a low incidence of thrombosis, lower DVT rates compared with the literature, which at the time was 4.9% for radiofrequency and 3.4 to 5.3 with surgery. The trained assistants of the Michigan group did the Caprini risk score on the phone using the app when they came in, and were able to do it very quickly and efficiently. Now, since that time, first of all, in all of 2019, there was only one symptomatic calf clot. I think in 2020, there were none, but I'm not going to suggest the answer, because from 2019 to 2022, they've put together their new results, and they're going to be presented at the American Venous Forum, and they asked me to tell you this and not reveal those results at this particular time. Here is the study using a direct oral anticoagulant. And this was rivaroxaban for the prevention of venous thromboembolism after ablation procedures. with or without mini phlebectomy, sclerotherapy, or no treatment of the tributaries. Rivaroxaban was given for 10 days, for 5 days in 10 milligrams with a Caprini score of 3+. And the results were compared with 79 traditional patients given low molecular weight heparin for 5 days. Primary efficacy outcome occurred in 5 of the patients, and 3 including 3 E-hits and 2 symptomatic DVT. Clinical non-relevant major bleeding was reported in 2 patients. So no difference was observed in comparison with the 79 similar patients who received 40 milligrams of enoxaparin. Conclusion is 1 day 10 milligram of rivaroxaban once daily for 5 days is suitable for VTE prophylaxis after radiofrequency ablation of varicose veins. Now let's talk about the common risk factors we use. Here they are. And I would note that procedures that last over 45 minutes score is 2. Don't forget to score the varicose veins as 1. And here is a suggested schema using Caprini score of 1 to 4, using compression stockings. For moderate risk patients, compression stockings, low molecular weight heparin or DOAC for 7 to 10 days. That's with a score of 5 to 8. And in those patients that have a score of 9 above, the same thing for 7 to 10 days, except a duplex scan before stopping the anticoagulant. It is suggested that one use 14 to 28 days of prophylaxis for a history or family history of thrombosis or thrombophilia, regardless of the score. And I would say that I put these together and we use them in our practice, and we put them up there as sort of a straw man. Validation needs to be done, refining this algorithm. What do we really need to do with the cutoff? How long do we really need to keep them going? And so on and so forth. So I'd like to conclude by talking about never kill a friend and never treat a stranger. Performing a thorough history and physical gives you knowledge about your patients as if they were a good friend. So once you get to know that person, you would protect them. So you would never treat a stranger and you would never kill a friend. So I'd like to thank you for your attention and refer you to my social media platforms for more information. I hope everyone has a wonderful conference, and it's been a great privilege to present these data. Thank you very much.